Hi there, I'm Dr. Thomas Martin from the University of California, San Francisco. And I'm here to talk to you about my poster at ASCO annual meeting 2021. And so with my colleagues, we presented a poster on comparison of cilta-cabtagene autoleucel, now known as cilta-cel, which is a CAR T-cell therapy, a BCMA-directed CAR T-cell therapy. It was tested in the CARTITUDE-1 study. And the focus of the poster was to compare CARTITUDE-1 versus real-world standard of care patients with triple-class exposed multiple myeloma. Now, patients who have triple-class exposed multiple myeloma, they have an overall a poor prognosis, especially when they become refractory to the big three. Proteasome inhibitors, immunomodulatory drugs, and CD38 antibodies. And they also have limited treatment options at that point in time. Now, cilta-cel was assessed in the CARTITUDE-1 study. It was a phase 1b/2 study. It was a single arm trial in these triple class exposed patients, the majority of which were triple class refractory. Now, the goal of this was to create a synthetic control group to compare cilta-cel to treatments used in kind of real world clinical practice. So the objective was to evaluate the comparative effectiveness of cilta-cel versus real world standard of care therapy in patients with triple class exposed multiple myeloma. The method we used, we selected patients from the Flatiron Multiple Myeloma Registry, which is a registry around the US, and it includes over 10,000 patients. Now we used inverse probability of treatment weighting, or IPTW method, to mimic the effects of randomization, and it corrects for the imbalances in prognostic factors between cohorts. And so the goal was really to analyze PFS and OS for these balanced cohorts from CARTITUDE-1 and from the real world Flatiron cohort. Now, and again, in the Flatiron registry, there's over 10,000 patients. We looked for patients that were exposed to an IMiD, a PI, and a CD38 antibody. And then we looked at patients who had received at least one subsequent treatment after being triple class exposed. And then we looked with patients with greater than 3 prior lines of therapy. They had a good ECOG score of less than 2, a creatinine less than 2, and who progressed on or within 12 months of their most recent line of therapy. And that was to just unite with the CARTITUDE eligibility. Now, we also looked at patients who had not progressed within 47 days of first eligible treatment. And that's because once patients had their lymphocytes collected on the CARTITUDE-1, it usually took about 47 days on average for them to be infused back. And so during that period of time, we didn't want to have patients in the control group relapsing and include them in the analysis. And so the prior treatments that patients were exposed to were, similar in the Flatiron database as you would expect in a triple class refractory population. Some carfilzomib, some pomalidomide, some lenalidomide, daratumumab, some selinexor, some panobinostat, cyclophosphamide, and even other alkylator-based therapy. Now, the populations actually were well balanced. We looked at a real world kind of observed cohort, and then we looked at the IPTW adjusted cohort. They're very similar in terms of their refractory nature, their ISS stage, their cytogenetic profile, the time to progression since their last regimen, and the number of prior lines of therapy. And so all these important characteristics were matched between the groups. And if you can see here, on the poster, we show the improvement in PFS in OS compared to the real world standard of care cohort. In terms of progression-free survival, the blue curve is the CARTITUDE-1 curve. You can see that is much higher than the real world observed cohort and the real world adjusted, the IPTW adjusted cohort. If you look at overall survival, you see there's also a very significant improvement in overall survival in those patients who received CARTITUDE-1 versus the comparator of the real world observed and the real world adjusted cohort. So, in conclusions, these data really show that there was a consistent improvement in outcomes with cilta-cel versus real world standard of care therapies. That's not surprising since we found out that CAR T cells have such a high overall response rate in triple class exposed patients, and they have a very deep response and a very good duration of remission. And I think the takeaway really is that cilta-cel offers substantially more clinical benefit than any currently available real-world standard of care therapy in patients that have triple class exposed multiple myeloma.